Hello everyone. In this video, let us discuss the diseases of the sclera. The sclera, as you can see in this picture, is the tough, white colored, opaque outer covering of the eyeball. It is derived from the neural crest and it is composed of collagen and elastin. The sclera is around 1 millimeter thick posteriorly and it is thinnest just behind the insertion of the recti muscles where it is around 0.3 millimeter thick. Coming to the layers of the sclera can be divided into episclera, sclera proper and lamina fusca. The sclera is pierced anteriorly by the anterior ciliary arteries and episcleral veins. It is pierced posteriorly by the vortex veins, posterior ciliary nerves and vessels, and optic nerve. The optic nerve passes through the lamina cribrosa of the sclera. Now let us discuss about inflammation of sclera. Inflammation of sclera can be divided into two types. The first one is superficial or episcleritis and the second one is deep or scleritis. First let us discuss about episcleritis in detail. Episcleritis is benign inflammation of the superficial scleral lamellae. Anatomically, there will be dense lymphocytic infiltration of the subconjunctival and the episcleral tissues. Coming to the etiology, it is thought to be an allergic reaction to an endogenous toxin and it is usually associated with rheumatoid arthritis. Coming to the clinical features, it usually affects young females. There will be acute onset of redness and mild pain. It can affect one or both the eyes. Usually there won't be any discharge and it is usually recurrent. Coming to the types of episcleritis, there are two types of episcleritis. One is simple episcleritis and the second one is nodular episcleritis. This picture shows a case of simple episcleritis. It is also known as diffuse episcleritis. In this case, there will be sectoral or diffuse redness, as you can see in the image, with engorgement of the large episcleral vessels. There can be mild tenderness. This picture shows the second type of episcleritis, that is nodular episcleritis. As you can see in this image, there is a circumscribed nodule. This consists of dense leukocytic infiltration. It is usually 3 mm away from the limbus, as you can see in this picture. The nodule is hard, tender and immovable. There can be little or no pain. Remember, nodular episcleritis tends to be more symptomatic and takes longer time to resolve when compared to simple episcleritis. If nodular episcleritis is not treated properly, it can rarely progress to scleritis. As you can see in the picture, it is usually temporal in location. It is transient and it has a tendency to recur. Now, how do you differentiate a case of episcleritis from scleritis? Cases of episcleritis, the vascular engorgement blanches with topical vasoconstrictor like phenylephrine 10%. So, if you instill phenylephrine and there is blanching of vessels, it means that it is a case of episcleritis and not scleritis. Sometimes cases of episcleritis can have fleeting attacks which are frequently repeating. Such cases are called episcleritis periodica fugax. These are basically episcleritis attacks which are fleeting and frequently repeated. Now let us discuss the treatment of episcleritis. For mild cases, we can give lubricants alone. For moderate to severe cases, we can give mild topical steroids like fluorometholone. Four times a day. This relieves the discomfort and inflammation. If topical treatment is unsuccessful, we can give oral NSAIDs like ibuprofen 400 mg 3 times a day. Other options include aspirin and indomethacin. Now let us discuss about the second disease entity, that is scleritis. As the name indicates, scleritis is dense lymphocytic infiltration deep within the scleral tissue. It is usually a bilateral disease. It is rarer than episcleritis, and just like episcleritis, it frequently affects women. 50% of the cases of scleritis are associated with underlying connective tissue diseases. So we need to do thorough investigation to find out the underlying connective tissue disease. Now, what are the connective tissue diseases associated with scleritis? These include polyarthritis nodosa, systemic lupus erythematosus, rheumatoid arthritis, ankylosing spondylitis, Reiter syndrome, and other entities like non-specific arthritis, vaginal granulomatosis, dermatomyositis, and gout. It can also be associated with ophthalmic conditions like herpes zoster ophthalmicus and recent ocular surgery. Now let us discuss the symptoms of scleritis. These include pain, redness, watering, and discharge. There can also be bluish or brownish discoloration of the affected eye. Now let us discuss about the classification of scleritis. Scleritis can be divided into anterior scleritis and posterior scleritis. Anterior scleritis can be further divided into non-necrotizing anterior scleritis and necrotizing anterior scleritis. Non-necrotizing anterior scleritis can be further divided into nodular non-necrotizing anterior scleritis and diffuse non-necrotizing anterior scleritis. Necrotizing anterior scleritis can be further divided into necrotizing anterior scleritis with inflammation and necrotizing anterior scleritis without inflammation. This is how we classify scleritis. Now, this picture shows a case of nodular non-necrotizing anterior scleritis. So, as you can see in this picture, there can be one or more nodules. They appear dark red or bluish and they later become purple. Sometimes they can extend entirely around the cornea, in which case they are called as annular scleritis. These images show diffuse non-necrotizing anterior scleritis. Remember, scleritis differs from episcleritis in that cornea and uveal tract are involved in case of scleritis. Also, scleritis can lead to the formation of ciliary staphyloma. When scleritis extends into the cornea, it is called as sclerosing keratitis. Sometimes the margin of cornea may become white like the sclera. There is another complication called keratolysis. This is a complication of scleritis where the corneal stroma melts away and it is a very serious condition. Now let us discuss about the next type, that is necrotizing scleritis. Necrotizing scleritis is associated with scleral necrosis, severe thinning and melting in severe cases. As discussed earlier, necrotizing scleritis is divided into necrotizing scleritis with inflammation and necrotizing scleritis without inflammation. This picture shows a case of necrotizing scleritis with inflammation. These cases present with red, painful eye, and there will be progressive worsening of symptoms. It is associated with anterior uveitis and it is usually a part of systemic autoimmune disease. There will be vascular sludging and occlusion, scleral thinning, and there can be complications like glaucoma, cataract, sclerosing keratitis, and peripheral corneal melting. Remember, the 5-year mortality from associated systemic disease in case of necrotizing scleritis with inflammation is around 25%. So, we need to properly investigate such cases and find the underlying cause. Now, let us discuss about the second type of necrotizing scleritis, that is necrotizing scleritis without inflammation. This is also known as scleromalacia perforans. It is usually associated with seropositive rheumatoid arthritis. Such cases, there will be painless scleral thinning and there can be melting in severe cases. It is thought to be because of ischemia. Remember, cases of necrotizing scleritis with inflammation present with pain, whereas cases of necrotizing scleritis without inflammation, that is cases of scleromalacia perforans, present as painless thinning. Now let us discuss about posterior scleritis. In this case, there is inflammation with thickening of the posterior sclera. It can start primarily or it can be an extension of anterior scleritis. It is usually not associated with any systemic disease. The clinical presentation is varied and the diagnosis is easily missed. Now let us discuss the symptoms of posterior scleritis. The patient can present with decreased vision. There can be pain or the patient can also present without pain. There can be proptosis or restricted extraocular movements. Now coming to the signs of posterior scleritis, there can be posterior vitritis, disc edema, macular edema. This picture shows a case of posterior scleritis with choroidal folds. There can also be choroidal detachment, uveal effusion as you can see in this picture with exudative retinal detachment. This picture shows a case of posterior scleritis. If we do B scan, we'll find out something called T sign. This is because of the thickened sclera. So this is B scan of a case of posterior scleritis showing T sign because of thickened sclera. This thickened sclera can also be picked up using CT scan. Now let us discuss about the investigations done for a case of scleritis. As we have already discussed, 50% of the cases of scleritis are associated with underlying connective tissue disease. So whenever a patient presents with episcleritis or scleritis, we should take a careful history, do a proper thorough systemic examination. Then depending on the clinical picture, we have to order for appropriate investigations. These investigations include complete blood count, rheumatoid factor for rheumatoid arthritis, Mantoux test for TB, ANA, that is anti-nuclear antibody test for SLE, anti-neutrophil cytoplasmic antibody test, that is ANCA for vaginous granulomatosis, VDRL and FTA-ABS for syphilis. We should also do chest X-ray for TB and sarcoid, X-ray of sacroiliac joints for ankylosing spondylitis. Now let us discuss about the treatment of a case of scleritis. For non-necrotizing anterior scleritis, that is for diffuse or nodular scleritis, we can give oral NSAIDs. If it is severe, we can start on oral prednisolone. The dose of 1 milligram per kilogram per day for the first 1 week, which can be tapered to 20 milligram per day over the subsequent 2 to 3 weeks. If it is very severe, we can start immunosuppressive drugs. The various immunosuppressives include cyclophosphamide, methotrexate, cyclosporin and azathioprine. Remember, whenever we are treating a patient with oral steroids or immunosuppressives, we should also give ranitidine or famotidine to prevent peptic ulcer. Now let us discuss about the treatment of necrotizing scleritis. As we all know, it is a more serious condition than non-necrotizing scleritis. So for necrotizing scleritis, treatment with systemic steroids and immunosuppressives becomes necessary. Remember, mild cases of non-necrotizing scleritis can be treated with oral NSAIDs, but cases of necrotizing scleritis almost always require systemic steroids and immunosuppressives. For necrotizing scleritis without inflammation, that is for scleromalacia preferens, abundant lubrication is necessary. Also, we can do scleral patch grafting whenever there is significant risk of perforation. Coming to the treatment of posterior scleritis, we can treat the patient with systemic non-steroidal anti-inflammatory drugs or steroids or immunosuppressives depending on the severity of the posterior scleritis. We can also give intravenous methylprednisolone as pulse therapy for cases of posterior scleritis to reduce the side effects of prolonged oral steroids. Whenever we are finding any infectious cause for the scleritis, we have to treat the infection with appropriate topical and systemic antimicrobial agents. Also, whenever there is panophthalmitis, we have to give intravenous antibiotics in meningitis doses. These pictures show a case of rheumatoid arthritis. As discussed earlier, episcleritis and scleritis are important associations of rheumatoid arthritis. In rheumatoid arthritis, there is deposition of globulin antiglobulin complex leading to the activation of complement. This leads to various clinical features like deformities of joints, as you can see in this picture, and rheumatoid nodules, as you can see in this picture. In the eyes, there can be scleral nodules, which are granulomatous response to focal deposits of antigen antibody complexes. There can be episcleral rheumatoid nodules, which can be waxing and waning. There can be necrotizing nodular scleritis. There can be scleromalacia perforans. There can also be massive granuloma of sclera. There can be brawny scleritis. These are all the manifestations of rheumatoid arthritis in sclera. How do you treat a case of rheumatoid arthritis? We treat with systemic corticosteroids. Now let us discuss about some infections of sclera. This picture shows a case of gamma, which is seen in tertiary syphilis. This is uncommon nowadays. TB can also affect the sclera. Whenever there is TB of sclera, there will be a localized nodule which caseates and ulcerates. TB of sclera is treated with systemic antitubercular therapy. This picture shows a case of pseudomonas infection of the sclera. Remember, there are two entities. One is endophthalmitis and the other is panophthalmitis. Endophthalmitis is infection and inflammation of the inner coats of the eyeball. So, in endophthalmitis, sclera is not involved. However, panophthalmitis is infection and inflammation of all the coats of the eyeball. In panophthalmitis, sclera is involved. So, in panophthalmitis, there will be painful eye movements. How do you treat a case of panophthalmitis? We give high doses of intravenous broad spectrum antibiotics. Now let us discuss about another important disease entity of sclera, that is staphyloma. Staphyloma is defined as ectasia of the outer coats of the eyeball with incarceration of uveal tissue. This outer coats can be cornea or sclera or both cornea and sclera. Now, the pathology in case of staphyloma is weakening of eye wall, which can be caused by inflammatory or degenerative conditions, and there is also associated raised intraocular pressure. Now, the various types of staphyloma are anterior staphyloma, intercalary staphyloma, ciliary staphyloma, equatorial staphyloma, and posterior staphyloma. We will be discussing about each of them in detail in the upcoming slides. First, let us discuss about anterior staphyloma. This picture shows a case of anterior staphyloma. Anterior staphyloma usually occurs as a result of sloughing corneal ulcer. Basically, there will be a corneal ulcer which perforates and heals. Whenever a corneal ulcer perforates and heals, there will be formation of pseudocornea. This pseudocornea is organization of exudates and fibrous tissue. This is basically weak, and because of the raised intraocular pressure, there will be bulging of this pseudocornea leading to the formation of anterior staphyloma. Remember, the definition of staphyloma is ectasia of the outer coats of the eyeball with incarceration of the uveal tissue. The uveal tissue in case of anterior staphyloma is iris. That is, anterior staphyloma is lined internally by the iris and externally by the newly formed pseudocornea. Moving on to intercalary staphyloma, this picture shows a case of intercalary staphyloma. It is located at the limbus of the eye. It is lined by the root of the iris and the anteriormost part of the ciliary body. It is seen externally from the limbus up to 2 mm behind the limbus. It occurs due to perforating injuries of the peripheral cornea. Marginal corneal ulcer, anterior scleritis, scleromalacia perforans, complicated cataract surgery with poor wound apposition, and secondary glaucoma. These are the various causes for intercalary staphyloma. Moving on to the third type, that is ciliary staphyloma. This picture shows a case of ciliary staphyloma. It affects the ciliary zone, that includes the region up to 8 mm behind the limbus. Here the ciliary body is incarcerated and the ectatic part is the sclera. It has a bluish color with a lobulated surface. Causes include developmental glaucoma, in-stage primary or secondary glaucoma, scleritis, and trauma to the ciliary region of the eye. These are the various causes for ciliary staphyloma. Now let us discuss about the next type of staphyloma, that is equatorial staphyloma. This occurs at the equatorial region of the eye with incarceration of the choroid. Remember, the definition of staphyloma is ectasia of outer coats with incarceration of uveal tissue. Here the outer coat is sclera in the equatorial region and the uveal tissue here is choroid. The equatorial region is around 14 mm behind the limbus. So whenever staphyloma occurs in this region, it is called as equatorial staphyloma. The causes of equatorial staphyloma include scleritis, degenerative myopia, and chronic uncontrolled glaucoma. Now let us discuss about the last type of staphyloma, that is posterior staphyloma. In posterior staphyloma, there is ectasia of sclera in the posterior pole of the eye and it is lined by choroid. The most common cause of posterior staphyloma is degenerative eye axial myopia. Remember, posterior staphyloma is not visible externally and it is detected by fundoscopy or B-scan ultrasonography. This picture shows fundus photo of a case of high myopia demonstrating posterior staphyloma. You can notice the crescentric shadow in the posterior pole. Now let us discuss about the treatment of staphyloma. As we have already discussed, staphyloma occurs due to inflammatory diseases of the outer coats of the eye. These inflammatory diseases can be scleritis or corneal ulcer or keratomalacia. This keratomalacia can be because of vitamin A deficiency or due to rheumatoid arthritis. All these conditions can lead to secondary glaucoma, which can eventually lead to the formation of staphyloma. So these conditions need to be managed appropriately to prevent the formation of staphyloma. Coming to the surgical management of staphyloma, we can do local excision and repair with a corneal or scleral patch graft. We can also do staphylectomy or keratoplasty, and if it is a large unsightly blind eye, we can do enucleation and put an implant. Now let us discuss about the tumors of sclera. This picture shows a case of golden hour syndrome. In golden hour syndrome, there will be limbal dermoid, which is a benign tumor of the sclera. Basically, limbal dermoids are choristomas. What is a choristoma? A choristoma is normal tissue in abnormal location. So basically, in this case, there will be normal tissues like hair follicles, sebaceous glands, and keratin in an abnormal location like the limbus. This is an example of benign tumor of the sclera. Coming to malignant tumors of sclera, primary malignant tumors of the sclera are rare, but the sclera can be secondarily involved in other tumors like retinoblastoma, as you can see in this picture, or it can be because of squamous cell carcinoma of the lid, malignant melanoma of the lid, or other lacrimal gland tumors. Such cases are treated with exentration. Now let us discuss about blue sclera. This is a congenital anomaly of the sclera. It is seen in hereditary conditions like osteogenesis imperfecta. In this case, the sclera and the cornea is thin, so the uveal pigment shines through. That's why there is blue color in these cases. Other diseases which can present with blue sclera are Ehlers-Danlos syndrome, Marfan syndrome, and pseudoxanthoma elasticum. Local ocular conditions like keratoconus and keratoglobus can also present with blue sclera. Now, let me give you a brief summary of whatever we have discussed in this video so far. So, sclera is the opaque white outer covering of the eyeball. There are two important conditions of sclera. One is episcleritis and the other is scleritis. We have discussed the various types of episcleritis and scleritis. Some key differentiating features being, in episcleritis there is mild pain, whereas the pain will be very severe in case of scleritis. This pain can awaken the patient at night. Other differentiating features include there will be reddish hue in case of episcleritis, whereas the hue will be bluish in case of scleritis because it is deep. In case of episcleritis, the vessels blanch with phenylephrine, whereas the vessels don't blanch with phenylephrine in case of scleritis. Remember, episcleritis is usually idiopathic, whereas in case of scleritis, there will be associated autoimmune connective tissue diseases in 50% of the cases. Coming to the treatment, episcleritis is usually self-limiting and we can treat with topical mild steroids, whereas in case of scleritis, we usually require oral steroids and immunosuppressants. We also discussed about various types of staphyloma and some miscellaneous tumors and infections of the sclera. Thank you.